information has been lost, and it has been difficult to engage the public beyond the level of more NHS funding or protecting hospitals from closure. And the work that Engage Britain have done, that I've been very pleased to kind of observe and support, has been understanding what really matters to patients and what a healthcare system would look like if patients were empowered, if patients were able to engage in some of those really challenging trade-offs that exist within the health and social care system. And so today's panel is going to be considering that question. If we put people first, what would it mean for our healthcare system? How would it change? What does that mean? National government, parts of the NHS, parts of the social care system, private actors like GPs would need to do differently. It's a massive topic. We're going to cover it all in about an hour's time. Let me introduce my panel. So to my far left, we have Julian Mcrae. He is the director of Engage Britain. He spent 25 years, I'm told, in the world of public policy creation, including about 5 as deputy director of the Prime Minister's strategy unit, where he led on social mobility, welfare and economic growth, and previously has done a lot of work with the Institute for Government, a fantastic fellow think tank. Next to Julian, you have Helen Whiteley, the Member of Parliament for Faversham and Mid-Kent. Helen's been the MP for there since 2015, was Deputy Chair of the Conservative Party under Theresa May, and was retained in that position by Boris Johnson, an honour that I don't think actually many people had between those two governments, so clearly a point of distinction, and has also served as Parliamentary Under Secretary of State for Arts, Heritage and Tourism, and Minister of State for Social Care. So very, very familiar with some of the topics we're going to be discussing. To my right, we have Bill Morgan, a visiting fellow at the King's Fund and Senior Counsel at Incisive Health, one of the largest health communications consultancies in the country. In May 22, he joined the King's Fund as a visiting fellow, particularly looking at the political obstacles to NHS transformation, and was previously a special advisor at the Department for Health in the 2010s, and worked on healthcare for the Conservative Party in the 2000s. And to the far right of the panel, you will note, is not Neil O'Brien. Neil O'Brien, in a slightly ironic situation given the topic, is unwell and has had a nasty bout of conference food poisoning. And so I am extraordinarily grateful to James Sunderland for stepping in at the last moment. James is Parliamentary Private Secretary in the Department of Health, so is working very closely. Working very closely with Therese Coffey on some of the big ambitions that this government has, particularly to clear the NHS backlog, to deal with some of the challenges around ambulance care. There is an A, B, C, D that I should probably know but have forgotten, but you'll know it off by heart, I presume.
There's also a E, F and G, which I'll cover as well.
I'm very, very excited for the alphabetic speech you're going to provide. We're going to allow James to go last, just so he has a bit of time to absorb the panel. And what we're actually going to do, unusually, is start with our partners for the event, start with Engage Britain, because Julian's going to share some of the work that they've done. We'll have a brief response from other members of the panel, and then come out to you all for some questions and remarks. So, Julian.
Great, thanks Adam, really appreciate it. And as you said, I spent about a quarter of a century working in policy making, and most of that was in the analytical side, the working through spreadsheets, data, etc., modelling of options. I suppose in setting up Engage Britain, it was almost a career mea culpa for me. That analysis is really important, but you can't do public policy without the public. And 3 things that we talk about at Engage Britain. Let people themselves tell you what matters in their lives. It gives you the questions you need to answer. The public generally has to support any political direction that a government wishes to take if we want to see it produce sustainable results. So what are the things, what are the values that matter to the public as they're going forward? And finally, if you want the detailed solutions that actually work on the ground, get the people on the front line, actually with the people who are using those services and the employers and, in fact, the policy experts, get them together and let them tell you what the answers that work in practice are. So that's what we've been doing, those 3 sort of parts of it. And I just wanted to briefly run through a few of the insights that have come out of that around health and care over the last year and a half. I mean, the thing I just want to say right at the top on that, what matters to people, that love for the NHS, that is incredibly strong. And you get in every discussion group I've ever sat in. But you need to be really, really clear what it's about and what it's driven by. It is an attachment to the ethos of the NHS. It is that free at the point of use. I was listening to Robert Jenrick, who started his talk earlier today about, you know, that is absolutely central to the politics, as it were, of this country. What it is not is a deep attachment to the way the institutions that form the NHS treat people in our society. Now, there are occasions, and many of us will have experienced it, when in a real emergency crisis situation you get an exceptional care from people who are exceptionally dedicated to caring. But equally, many of us will have experienced the frustration and hitting up against those, you don't know where to turn, you're not quite sure what's happened with a referral, etc., etc., etc. And actually, when we did this in discussion groups, we found the language of fighting to get care was something that came up again and again. We took that into a bit of polling. About 25% of people in this country have shared the experience of having to fight to get care that they need. That's heading up for 15 million people. Now, that is not a situation we want to be in. And the stories are repeated and repeated and repeated within that. What we've done is a bit of work that follows from it. First thing I'd say is, one, this is not a patients versus providers split. Actually, if you look at people's reactions, again, taking some polling that came out of language people use in discussions, you know, they feel the staff in the NHS are overstretched and doing the best that they can. They may have had experience of individuals who they feel have let them down, but in general, there's a gratitude to people who dedicate their lives to caring. And actually bringing together those staff and bringing together patients, you can find throughout the NHS, there are really great examples of where the communication with people is so much stronger. Things along the lines of, I think it's Blackburn and Darwin, they've got really lovely systems where the GPs are actually using people in the surgeries to help people find the treatment that they need. And that's for the basic triage, the basic first encounter with the NHS. In northwest London, there's a really beautiful initiative around connecting care around children for people with much deeper needs, where the GPs take responsibility for just making sure those children and their families, the services are being joined up around them. And actually helps the GPs themselves, because they get access to some of the specialist advice at the same time while they're coordinating that. These are examples of things that are actually happening in the NHS now. There's no need for extra funding, no need for anything. They can happen within the envelope at the minute. The issue is they're happening almost randomly throughout the system where people are just interested in them. So one of the big questions, I think, for a government is how to champion that view that patients and their experience matters. This causes real mental health suffering to people, and it's preventable. But how do we make sure that a system that concentrates on a load of clinical things correctly also concentrates on how it treats and interacts with people? The second thing I wanted to touch on was things that matter to the public generally. Now, one of the big issues, and I'm sure we're going to come to it, especially with Helen sitting to my right, social care has been something where there is a real problem. It's a problem that's been recognised for at least 20 years across a range of governments. And it's a problem that our political system, our policy world, we have failed to actually address in a comprehensive way. Our take at Engage Britain is that the problem is that the cases for reform that have been made, and they have been made by successive governments, have never managed to resonate strongly enough with the public to make them irreversible. And we ran quite a lot of deliberative events trying to really understand, well, what is it that the public really care about around social care? And it will not surprise too many people in this audience that they don't really recognise the word social care, what exactly those services are and how they differ out from the NHS. And they're interested in, but they will never come back to in discussion some of those things that are aligned around it. How do we help people with really long-term disabilities lead as independent a life as possible? How do we best have a frail old age? I'm afraid while people will engage in those conversations, they don't want to return to them. And then we could talk about why that is. The one thing we found in the deliberative work we did that people came back to again and again and again was carers. And it was part of that gratitude for people who dedicate their lives to caring, and a sense that we do not have enough carers in this country. And when I use that word, it wasn't just enough people who work in care they were talking about. They were talking about people who have a vocation for caring, who want to provide that support and that deep care to people, and working in ways that allows them to build those relationships, which can be very different to what happens when we get trapped into cycles of small extra bits of funding just to get enough hands into the system to deal with the problems we've got at the moment about discharging from hospitals, the problem we have at the moment about care packages falling through and people then actually coming back into our hospitals because they haven't got the care in their homes. We got a group of people who work in care, a group of people who use care, people who are employers, commissioners out of the local authority side, and again some experts, very grateful to Ethos for providing some people into that. What does it need, what do we need to do to actually get a care workforce that the public really wants and is getting higher and higher on their priorities as time goes by? Some of this is really straightforward and not expensive. It is about recognition and dignity in those roles. One of the things that actually we really liked came out of this was it was very practical. People will know that people have problems parking near domiciliary care when you're going into someone's home. How do you park when there's parking restrictions in the area and the time it takes to actually get there? One of the suggestions was just simply, if we disable parking a blue badge, why not have a green badge for carers when they're on duty so they can actually park near the people they're caring for. The reason for that was practical, but it was also about a society signalling the value of caring and being able to get to people to care for them. There are other things about carers being actually directly involved in the assessments of people they're caring for and things like that, which raise status. And then there are things which cost money and inevitably cost money given where we have got to with some of the funding issues. And that's things like how do we create actual career progression? How do we not make this just about qualifications, but actually about experience of providing care, which is quite a different thing, and the thing that some people are actually really involved in caring for. How do we create pay structures which have that parity with the NHS, and not just parity because it's about pay, but parity because it's about esteem. Those are a whole set of issues which I think the government now, I'm sure, is thinking very hard about and how it does it. So I'll finish up there, but with just one last thought, which I think Bill might well touch on. The other thing that comes out from dealing with the public is workforce and the health workforce. So I've talked a bit about care there. For them, having enough people who work as doctors, as nurses, as GPs, it's absolutely essential to sorting waiting lists and sorting GP access and all those things. So how we deal with actually getting our healthcare workforce out of the situation we've ended up in with real shortages and actually have enough people working there is absolutely critical to the public as a whole. Indeed, they won't really start thinking about too many of the other things until that is sorted. And they're certainly not going to give any government credit unless they see it actually being sorted in the healthcare system.
Fantastic. Huge amount there. I've kind of pulled out the 3 C's, kind of communication, carers, and then careers. I guess the third is workforce, but I wanted some alliteration. So hugely important. I mean, look, Helen, you've been in this system, leading an enormously difficult time during COVID. Do some of the things that Julian found in the work resonate with you, and what might they mean for reform?
Yeah, I mean, absolutely what Julian said hugely resonated. And starting out where you started out, where the conversation started out, the first point was the importance of understanding what actually matters to people. And that might seem obvious, but actually lots of people have different views and different things matter to different people. One of the things that I was exploring as social care minister looked into both for the work on social care reform that went into the white paper and announcements, but also actually doing the work in the pandemic, we're seeing what do people want out of social care. Some people, it's all about living as long as possible. Other people will look at the trade-off differently and might say, well, what it's really about is quality of life. And if I don't have quite such a long life, but I have a better quality of life, then for some people, actually, that's what they want. So understanding really what people want out of the health and social care system is really important to getting then what we do and what everyone does right. I think also really important when we think about patients want to patients want, the family around the patient is so important and sometimes gets missed out. So too often I hear, for instance, of an appointment that somebody's had with a doctor, particularly if they're older but not necessarily, and husband or wife or carer wasn't kind of allowed in the room, wasn't in the room, or just happened not to be there for the conversation because it was during a ward round. And that carer is going to be really affected by whatever decisions are made in any about somebody's care. So actually really thinking about what families and people around patients want as well as a patient. There's a balancing with patients' individual rights and confidentiality. But, so this is complex territory to navigate. But sometimes I think the family around gets overlooked. I will say, I was going to compliment and welcome Neil O'Brien as the new social care minister.
Thank you so much.
Brilliant. We have James boldly Gamey stepping in. But,
a very poor substitute.
You can pass on to Neil, and it's fantastic that Neil has taken on that brief. I know it's in very good hands. And also Therese Coffey as Secretary of State, and she is, first of all, one of the top things she's already pulled out was the importance of focusing on patients and what patients want, clearly as part of that understanding it. I think, in preparation actually for coming here, I spent a little bit of time in my casework folder for Faversham Mid-Kent looking up what do my constituents tell me that they're most concerned about at the moment, what do they most want, and what, I think, to pick up on one of the things in the note about it was affecting their confidence in the health and care service at the moment. And the things that came up particularly were coming through was waiting for ambulances, access to GPs, waiting in A&E, waiting times for routine operations where people's quality of life was being affected. But I found my constituents were kind of quite understanding about the backlog and COVID on that, but clearly things affecting their lives. And access to mental health care, which has, I think, been a continuous thing that comes into an MP's inbox despite all the efforts to improve access to mental health. But the thing that I think really did stand out for me as a very current thing is ambulance waits. And that's clearly very, very frightening for people, whether it's those who experience waiting for an ambulance for themselves or somebody else, or the worry that you might have to wait for yourself or somebody else. And reading and following up on some of the experiences my constituents have had, waiting several hours through the night for somebody when they think it's really high risk moment. It's affected my family personally as well. That is a very urgent problem to fix. And in terms of what patients want, some of these things are you've got to address some of the just being confident that if you urgently need medical care, you can be confident of getting it, which is something we know is something in this country we should be proud of being able to do. But I think in terms of then taking a step away from that, and I think a bit about solutions. I'm always interested and care most about what can we do to make things better. So why I'm in politics, and quite a few of the answers to those big challenges are, they're not. It's not going to be novel. And Bill, you've been working in health policy for a long time. We know, and the system knows a lot about what needs to be done, but it's not easy. And we all know about the importance of keeping people out of hospital and getting people out of hospital when they're ready to be discharged. And if you get those things right, then you can help solve the ambulance problem, which is a lot to do with the delays in the flow. So I'll focus on a couple of things that would be priorities to me. The first is clearly social care, and that's particularly the discharge challenge, which is very well known. Though Julian, I think you said it's been a problem for about 20 years. About 30 years ago, I did some work experience in a local hospital, and I was thinking of becoming a doctor at that point. And I was helping observing in the intensive care unit, and they were trying to bring a young girl into the intensive care unit, but somebody was ready to leave the intensive care unit. There were no beds in it, free, but they couldn't leave because somebody else couldn't be discharged because there wasn't social care available. So this does really go back a long way, but it has indeed got worse again recently, and some of it, the problem is the supply, the availability of social care, which is why I think the social care reforms, the work I was involved in and Neil and others are taking on, are so important. A really important part of that, and it gets kind of technical, is the commissioning of social care by local councils. Local councils are so important to social care. So much of social care is that, which is commissioned by councils, and in the reform proposals is a significant programme of supporting councils and greater scrutiny of council commissioning, because that affects the quality and quantity of social care. In essence, I try not to get too much into the depths of that, but that's clear. The supply is really important to being able to enable people to be discharged from hospital when they're ready to be. The other area, clearly an absolute priority, is on access to GPs, which has become much more challenging recently. I was reading the Better NHS blog, which I imagine some of you in this room read over the weekend, and that had a stat, I think it was from the one practice, that the requests for on-the-day appointments have gone up 30% since the pandemic in that practice. I mean, that's a huge increase in demand for GPs, so of course really, really hard to meet, and around 7 in 10 of that practice cases are kind of chronic and complex, not easy to solve. But there is stuff that is working, and I know from practices in my constituency, for instance, stuff that's working. When practices are using an expert to triage cases every day and triage the phone calls. I'm seeing a nod, that's very reassuring, to have a clinical expert who triages and decides who really needs to be seen when and by whom. That really works. Having a broader team of people around the GPs, particularly the role of pharmacists, can really work and really make a difference. Relatively simple things like better phone systems, so people aren't desperately phoning up at 8 o'clock and 8:01 and 8:02 and 8:03, which means that some people don't get an appointment just because they can't practically do that. I was recently being driven in a taxi who got a call back from his GP because he'd been desperate. He had to, like, do you mind if I take a call from my GP while I'm driving you? And I really felt for this guy because, like, he didn't want to have a call with his GP while I was there, but, like, he was really struggling to access it. So better phone systems. So some of this is, like, management, and I make the argument for management because quite often when people look for sort of savings that they can make in healthcare, it's like, well, let's get rid of the managers and administrators, and I think obviously, like, we should be careful about that because management and running things well does actually really matter. And I think just the final thing I'll touch on is people, which Julian, you talked about, and the importance of people. The NHS is getting more nurses, and we're over halfway to increasing the 50,000 more nurses. But, like, the fact is that the demand exceeds supply. But we do need to not only clearly recruit and train more people, but really, really look after the people who are there. And I would say some progress, I think, and for those of you who work in the health and care sector, I hope that you felt during the pandemic there was progress made on valuing people. I certainly spoke to people in hospitals around me who said that the mental health support for NHS staff has improved following great efforts that were made during the pandemic to make sure that support was there for people. I think there's further to go for care workers. One of the big things that I certainly pushed for as care minister in the pandemic was to always talk about health and social care, NHS and care workers, and to think about them together with parity of esteem, because there's a lot of overlap between the jobs and equally important. And I think more work on the careers and opportunities for people in care work, and I think joint training are things which I know are kind of some of the things in the workforce aspect of the social care reform. But I think, between some of those things, if we can improve social care supply, get better on GP access, and support and retain as well as recruit people, and keep going at management and actually sharing best practice and technology. All of those things are things that come together to make the service work better, to give people more of what they want. So it's not rocket science, but nor is it easy. But it requires hard work plugging away at it. Hard work rather than headlines, probably. But I think we do, and across the system, people know a lot of the answers are. But working together and getting it done is what it's about.
Thank you, Helen. You talked about some of the hard work that needs to be done. Bill, you're someone that's been on the front lines politically of some of that hard work. Well, you've had advising the front line next to getting some of those reforms done. So your reflections on some of the challenges that have been outlined and how we can improve the system to address them.
Yeah, sure. I'm looking at the title of a fringe, how can a patient's experience of the NHS and social care inform and improve its future? And as Helen said, I've been involved in health policy for the best part of a quarter of a century now, which makes me feel very old. This kind of question could have been asked at fringes 20, 22, 25 years ago. So it's, we're here debating the same issues. And the reason why I think we are is because, as Helen said, it's not rocket science. The answers aren't known. We've known the answers for decades. It's about implementing the answers are hard. So, in my view, using the patient experience to improve NHS services. Firstly, you need more choice. You need to give patients more choice, and choice of provider and choice of doctor, or treating clinician. But of course, if you think about implementing that choice, then it's not too far before you begin to implement competition in the NHS, and of course that becomes very politically challenging. So that's one of the things you need to do. You need to equip patients with more information, and give patients themselves more information about the clinical options which are available to them. But then of course you bump into issues about where the correct balance between patient and clinical input is. And clinicians, feel very strongly, and rightly so, that they need to be able to inform patients on the best course of treatment for them. So choice, information, and personalisation is also very important, and particularly the implementation of personal budgets, which I know Helen was very focused on when she was social care minister. Because of course, if you give patients or service users personal budgets, you allow them to take the decision themselves, almost free of any sort of bureaucratic constraints. And I think one of the things actually which could help now with the discharge issues is if you gave patients personal budgets at the point of discharge, so that if they know that they need to hire a handyman to move their bed downstairs so that they can be safely discharged to their home, then they can do that easily, and they don't have to wait for a bureaucratic system to join up the dots and do that, and it helps patients get discharged from hospital more quickly. So I think choice, information, and personalisation are the way to make sure that patients' experience is embedded in improving the NHS. Of course, I think given where the NHS is now and the pressure that is placed on the NHS, I think even thinking about implementing those kinds of reforms is very, very hard for a government to do. As Helen said, her casework is full of ambulance delays. If you can't organise a healthcare system to get an ambulance to someone who needs it quickly, you're gonna have trouble thinking about choice or information or personalisation. So that is really the number one issue. And of course, the problem isn't in ambulances, it's just showing up in ambulances. The problem is there's just too much demand at the moment on the NHS's available capacity. And that's where we do get into staffing, as Julian said. And I think, right now, the priority for this government has to be to bring in staff as quickly as possible. We've got 100,000 vacancies in healthcare, we've got 150,000 vacancies in social care. We need to bring staff in. And that's the only way we're going to get out of this situation we find ourselves in with the NHS at the moment. And of course, they have to come in from abroad, realistically. We can't train up healthcare professionals overnight so that they can work in the service this year. And of course, the constraints on the social care workforce are well known, so realistically that needs to be fed by migration as well. And then we get on to the long-term staffing situation. This is the work that I've been doing with Julian and at Engage Britain and the King's Fund. So Julian very helpfully sent me the question back in May, why can't the NHS train the staff that it needs? And stupidly I agreed to have a go at answering this question, because I thought, how hard can it be? Because there's plenty of young people in this country who want to become doctors, who want to become nurses. So it seems totally irrational that we should have shortages of doctors and nurses. I was set the task of trying to find out the answer to this, and it turns out that we've had this problem since the dawn of the NHS, and probably before. Nye Bevan, when the NHS was set up, wrote a plea for help because the NHS was short of 30,000 nurses. And there's been no decade since where the NHS has not been short of staff in some way. So I've been trying to find out, and obviously speak to loads of people, Treasury and the health service in the NHS, trying to find out what the answer to this challenge is, why it exists. And I think it boils down to sort of three headline issues. The first is that workforce planning is unbelievably difficult in healthcare because of the lead-in times of training doctors and nurses and other healthcare professionals too. So, you know, it takes upwards of 10, 15 years to train a consultant, best part of 5 years to train a nurse, 3 years before we get into clinical practice. And of course, in these periods of time, so much can change technologically, legally, people's working preferences can change. You know, we've just gone through a pandemic which has impacted on everyone's working preferences. So it's very, very hard to forecast how many doctors you'll need in 15 years' time with any sort of degree of accuracy. So you've got to guess. You've got to guess at the number of doctors and nurses you need. So that's the first reason. It's hard. But then, of course, if you've got to guess how many doctors and nurses you need, you'd expect half of the time to end up with too many and half the time to end up with too few. You wouldn't always see too few doctors and nurses. So why do we have too few? I mean, the second reason, I think, for why we have these problems is that there's this tendency to undersupply in the system, which is caused by a few things. Firstly, the Treasury fears oversupply. The Treasury fears training up too many doctors, because then they think that they might have to employ them. You know, if you've got unemployed doctors, it doesn't make any sense to have them out of work. So the Treasury fears oversupply. So of course, if you can't oversupply, you end up undersupplying. So that's the first reason, Treasury. It's not just the Treasury's fault, though. It's not always the Treasury's fault. The second reason is politicians, I'm afraid. For good reason. Politicians, with the budget that they have available, will want to spend money fixing the immediate problems here and now, rather than investing in long-term improvements in services. And we see this with capital investment in the NHS. We see it with public health investment. And it's the same with workforce. It's perfectly logical politically to invest in the here and now rather than in the future. So that's the second reason. We tend to undersupply. But of course, then, if we undersupply, then we shouldn't necessarily be short of staff, because, as I say, we can bring them in from abroad. And indeed, for 70 years, de facto, we've always brought in staff from abroad. We've always been reliant on doctors and nurses from overseas. We have 1 in 3 doctors who work in the NHS now from overseas, slightly less, slightly fewer proportion of nurses. So the reason why we end up with shortages is because our migration policy and the NHS's needs and social care needs aren't aligned, basically. So for those 3 reasons, we have shortages of staff. Firstly, it's very hard to plan. It's very hard to do workforce planning in the NHS because of the lead-in times. We tend to train up an undersupply of staff, so we have shortages. And then to mitigate those shortages, we need to bring staff from abroad, over from abroad, but we are unable to because the migration controls don't always dock with the NHS's needs. So that's what I've been able to find out in terms of why we have problems and why we have chronic shortages in the NHS for decades and decades. And in terms of the solutions to that, I'm working on them now.
Thank you very much, Bill. There's never a twist in a policy whodunit. It's always the Treasury.
Yes.
It's the Treasury. James, let me come to you. The benefit of going last is you had some more time to think about your comments. The peril is you've got a huge number of policy recommendations there, ranging from fixing phone systems right up to fixing a century-old problem with social care recruitment. But I want to bring it right back to patients. So, Therese Coffey has signalled that she wants to be a patient's champion. One of the 3 things that Liz Truss talked about on the steps of number 10 was fixing some of those NHS backlogs. So the NHS is clearly at the centre politically. How are you going to ensure, and you and the team ensure that a patient's voice is right at the centre of that?
Well, look, good afternoon, everyone. It's great to be here, and thank you for the invitation to attend. 5 minutes notice, okay, so please bear with me. Neil can't be here. I think the first thing I'd say is that, for those who don't know me, I'm James Sunderland. I've spent 27 years in the MOD in uniform, so perfectly placed to be the PPS in health. What can I bring to the party? Well, I think the first point is this. To bring this back to a macro perspective, first of all, it's really important that we recognise what the NHS is. It is quite unique, it's quite special. It performed wonderfully during the pandemic, as it has done since its conception. And having served all over the world, where a lot of countries don't have any healthcare whatsoever, I think we need to manage expectations. So for a politician like me, this is about managing expectations and making sure that we're not expecting too much from an organisation which is bursting at the seams. I think the second thing is to dispel a myth. The NHS is not for sale, not at all. It's not a political football that the left would kick us with all the time. It's a very, very important organisation that is loved by us all. So the suggestion that the Conservatives aren't going to invest in it is complete nonsense. It is better funded now today than it has been at any time in its history. Fact. And it's not for sale. And I think also we need to recognise that where we are today is a reflection of the pandemic. The NHS was bent completely out of shape, and therefore what we've got to do is put it back to the way that it was, but also make more efficiencies and get it better for the future as well. So that's my opening contention. The second thing is Therese Coffey, who I know reasonably well, is absolutely the right person for the job. She's brand new in, she's very pragmatic, she wants this to work, she wants the NHS to succeed, which of course it will. And her plan, that those of you have seen, is worth looking at. The ABCD plan, and it's on the gov.uk website. Have a good look at it, have a read of it. She's absolutely right to bring us back to basics, to focus on what's important today. So just as a reminder, ambulances, we've got to sort that, no question about it. The backlog, no question about it. It's very easy to admire the problem, but this is what we have to do. Care. We've discussed social care, we've discussed the care workforce. It is fundamental that we get care sorted out, and of course doctors and dentists. We need to make sure that we are reducing wait lists across the piece. I've just been to a mental health workshop for the last hour, and I was informed in no uncertain terms that A, B, C, D needs to be augmented also by E, F and G. What's E, F and G? Well, first of all, equalities. Yeah, really important, because we've got parts of the country with healthcare that's not as good as other parts of the country. I'm an East Berkshire MP. Frimley ICS is the local health provider, unequivocally the best in the UK in terms of performance. You know, my constituents have got Wexham Park, they've got Royal Berkshire, they've got Frimley Park, they've got Brants Bridge. We've got amazing healthcare locally. That healthcare needs to be the same right across the country, and that's part of the levelling up agenda, which we've been discussing also. Funding. Extra funding is not the answer. It's not the answer. The UK is £2.2 trillion in debt right now. We've got to make better use of the funding that the NHS currently has, noting that it's better funded than any time in its past. So it's about how we use that funding and how we extract more for the machine. Come back to that in a minute. And the third thing is growth. G is growth. You know, the budget that's been discussed a lot in the media over the last week, absolutely the right thing to do. Services don't grow on trees. We have to create the wealth to pay for our public services. So it's absolutely right that we incentivise those wealth creators in the UK, businesses, the wealthy, working people, to extract more from them, to get more money in, so that we can afford to pay for better healthcare. And there's no question at all that we need better healthcare. So having discussed the problem, what's the solution? Well, I haven't got the solution right now today, but it may well be that A, B, C, D, and E, F, and G is the way forward. But I've got 4 points just to finish off with. First thing is, no question at all, we've got to get more out of our workforce. That doesn't mean thrashing those fantastic people we've got right now. We just need more people. Okay? So let's bring our retired personnel back into the workforce if they want to come back in. Let's incentivise it in terms of fix the pension mess, which means doctors don't want to come back in. Let's get more out of our nurses. Let's extend the age. My mother's a nurse. You know, she's, how old am I, 52? She's 73 and can still work and wants to keep working, which is fantastic. We also need to turn the tap on. So if we need to bring extra people in from overseas, absolutely, let's do it. Businesses in my part of the world are struggling, can't get enough staff. But the solution is bringing more people in, but also sweating the workforce that we have in the UK, getting more out of those people that live here, getting them back into the workplace. My second point, really important point, locums. It is absolutely ridiculous that we're paying locum doctors over £1,000 a day. That has the effect right now of GPs not signing up for contracts becoming partners with GP surgeries, it means that people are sitting at home doing 3 or 4 days a week, 2 days a week on £1,000 a day. No, let's get a cap in there, so let's get more GPs back into permanent employment with our surgeries, so that you and I can go and see a GP when we want to. More GPs in the workplace, not sitting at home on £1,000 a day, working part-time, is the way to go. The third thing is, we value our people by telling them how important they are and by paying them a decent wage. Yes, extra money, it's going to cost more money, but ultimately, you value people by telling them they're important and also giving them that ability to have money in their pocket to afford to pay their bills. And why wouldn't we pay our fantastic key workers a bit more money? Really important. And the fourth thing, my final point, is this. The solution is not more money, in my view, it's better management. It's efficiency, it's avoiding the wastage. We've got to get to grips right now, today, with our senior management in the NHS. These senior executives earning the best part of £500,000 a year in some cases, absolutely ridiculous. We need to write into their contracts performance targets, we need to hold to account. People that are not performing need to be sacked, in my humble view. Let's reinvest the money that we're spending on executives and management into those who work at the coalface. Really important. We've got to streamline the management. We've got to make sure that the money's going to where it needs to go. And we need to make sure that people are actually doing what they can to reduce the expenditure of the NHS, to reduce wastage, prescriptions, the list goes on. It's about efficiency and about improving how we do business. Thank you.
Thank you, James. So we're going to open up to some questions from the floor. I'm going to take a cluster of about 4, and then I'll direct them to members of the panel. We're going to go about 15 minutes or so, so I'm going to be quite selective. Oh, more hands went up at that point. Great. Okay. I'm going to go 1 down here, 1 at the back there, 1 at the front here, and then 1 just there. And then we'll see if we can get time for any more. So, question at the front there.
Hi. Thank you for all speaking on the panel. I just wanted to ask, we sort of all know what the issues are: parity of esteem for care workers and pay. We know that we need to look more at social care and stop calling them unskilled workers. Bill, you mentioned that we need to recruit more workers from abroad. That might be the case, but are we going to be paying them better? Are we going to be giving them career progression? You can't just bring people in, make them work for nothing, and then expect it's fine because they're from abroad. And what are we doing to support people with learning disabilities in social care? Inpatient units, I know, was a big discussion when you were in post, Helen. But what is happening with transforming care and the agenda? I don't see anything happening so far. I'm hearing talk about ICBs, hearing talk about this integrated system, but a lot of the funding that we're talking about going towards the integrated system is more towards health, and social care seems to be neglected. Also, just on the last point with the last panelist, on social care was massively underfunded before the pandemic. Before the pandemic actually hit, massively underfunded, neglected, and still seems to be the case. There are lots of people with learning disabilities who are not on the learning disability register, they're not getting their flu jab this winter, and they're not aware of the support that they can get and should be offered.
Excellent.
So I just want to know what the panel think about that.
Excellent. You snuck 3 questions in there.
Sorry.
So 1 on pay and career progression, 1 on people with learning disabilities and social care, and then a 3rd on the underfunding of social care. So I'll make sure we get answers to each of those bits. No, you're quite all right. You're quite all right. Question in the back there. Yeah.
Thanks. I'm Sam Royston. I'm Director of Research and Policy at the charity Marie Curie that works with people living with terminal illness. My question is about 24/7 care, and it's good to kind of hear that mentioned, but only really in passing. I think what we see far too often is we have a health service that works for about a quarter of the hours in the week. But the trouble with terminal illness is it just doesn't respect the clock. People are dying 100% of the hours in the week, and we don't have care provided outside of emergency care for about 75% of that time. And that is a key factor which is driving up that use of emergency admissions, particularly at the end of life. And so if we want to reduce our ambulances and promote better access to ambulances, we have to deal with better 24/7 care. So I'd be really interested in hearing the panel's thoughts about that.
Excellent. So 24/7 care question there. A third one was down here, I think.
Jessica from Local Government Chronicle. What I'm hearing more and more from councils, I'm asking this question to you, James, but I'm hearing more and more that there's an issue with bidding wars going on between social care agencies. So I've heard this a lot with children's social care, but I'm hearing it more with adult social care as well, that between areas what's happening, for example, I heard this morning in Nottinghamshire, Nottinghamshire offered to pay social workers £30 an hour, Nottingham pays 35, they have to go up to £40 an hour, and it's the pay is getting ridiculous. So I think there are now calls for like a cap on pay that will then stop local authorities from having to compete with social care agencies who are creaming off lots of profits from the system. And as I said, this is certainly an issue in children's social care agencies, but I think it's actually happening more and more in adult social care too.
Thank you. So a question there about the bidding war potentially between local government. Question just there, yeah.
Hi, my name's Liz Jones. I'm the Policy Director at the National Care Forum, and we represent not-for-profit care providers. It's lovely to see you, Helen, and it's good to meet you, James. So I think we are facing a lot of challenges. Our members are really struggling to deliver that better pay and better career opportunities for our staff. So it would be great to hear about the plans to build on the reform programme that was announced when Helen was running the show at that point. And I think also it would be interesting to hear your views on how you might want to make the most of the not-for-profit care sector in resolving some of these really big pressures around hospital discharge, kind of longer-term proper planning in communities to meet the needs of the people who are ending up in hospital, both in terms of supporting discharge, but also that bigger kind of preventative piece. And the pressures in the system at the moment mean a reduction really in that opportunity to build in that preventative work, so you're constantly responding to crisis with a missed opportunity for prevention.
Excellent, thank you. So particular question there about where some of the work has got to with support for carers in the broader workforce. I'm going to guide through those questions. We've got about 10 minutes left, so forgive me if I'm slightly directive with how we do it. Bill, I want to come to you first on this question about 24/7 care. So I know this is an issue you will have worked in both in government and during your time with the Conservative Party. How do you think about having an NHS which is able to be responsive and high quality at all hours?
Well, I'm in favour of it. I think of course, again, it's, you know, as Helen said earlier, it's not rocket science this stuff. It's just very hard to do. You know, we don't have sufficient staff at the moment. So it's very hard to see how you can expand the amount of, like, in terms of just time, the amount of care which can be delivered. So we need more staff. It comes back to that. But of course, if you begin to then think about, we need a 24/7 NHS. I remember a chap called Jeremy Hunt who tried to reform junior doctors' contracts to help deliver this, and it didn't end very well for him. So you end up in quite tricky political places quite quickly. That's not to say, of course, it's not the right thing to do. It's just politically it becomes quite, you know, challenging to get there. So I guess that would be my observation on that. I'll leave it to the politicians to work it out. Just on the overseas point, I do want to come back on that because it's a very important point you raised. As part of the work I've been doing with Engage Britain, we've been speaking to pollsters, we've been working with Engage Britain's People's Panel, who are a sort of focus group, a representative focus group. And the idea that you bring in workers from abroad and undercut domestic staff is very clearly a red line for people. They will not accept it. So if you do need to accept a system in which your migration controls are a bit more open to bring in staff that we need, you've got to absolutely make sure that you're not undercutting staff, because the people, you know, the public won't accept it. It's a bit easier in the NHS because everyone's on agenda for change anyway. So there's a standard contract there. Of course, in the care sector, it's a perfectly open labour market, so you do run that risk. How you solve that is something I'm trying to work out at the moment, as I say, but it is very much a red line.
There we are. Julian, let me come to you. The kind of cluster of questions we got, particularly on carers and what needs to be done to support them, something that really clearly came out in your research and was part of two of the questions here. What do the public think needs to be done, and what, in policy terms, are you recommending or focusing on in terms of valuing and supporting carers?
Yeah, I mean, thank you for that. I was quite struck by how much of the questions in this were coming back to care and how we clearly know it's integrated with all the things, ambulance problems are the start of this.
Mm-hmm.
I mean, in terms of the public, I mean, it is still that problem that a lot of the issues around the care sector for people who know those issues don't resonate strongly. And that, just even understanding that care is not just about people who are elderly and people who are patients, but actually a huge amount of care is on people who are looking to live an independent life. They are not interacting with the NHS in that sense. And I should say in this context, it was mentioned personalisation and personal budgets. If you're looking for things that come through when people are discussing their experiences in a very positive way, it is those experiences of having greater control, having greater budgets, and especially when it's about stuff that doesn't need to be medicalised. This is not part of what's occurring. So there's a huge amount there about how do you get that policy agenda, because it takes, it's combined in with that old age care, up and running and playing. And I wish I could say I have an answer to that and how you get the public into it, but what we found was it was very difficult, especially if people are talking about health, because they just, even though they think they're talking about care examples, they constantly go back to the words about patients and treatment. So there's something there. As we say, our focus is on carers, because it plays very strongly. It is a different type of thing. It's not just workers. How you do the migration controls is absolutely essential to whether we're getting in carers who can look after people we really care about, and or whether we're getting in people who are just working in the care system, which is very, very different. There's a huge problem that we've taken the finances to a point where care packages are effectively designed by the finance department. It is about a control of cost. And if you talk to people who are, who will be depending on care packages across 20, 30, 40 years of life, whole of life, that fear of the annual review and the fact that they know they're going to meet somebody who has probably never met before, who has the power to remove their care package and is incentivized to find savings because the departments are under such pressure, that is a deeply traumatic experience. So how do we take something that is about financial control and turn it into something that is about actually empowering people's lives and helping them live? So all of those things kind of come together in, I think, actually a way of starting to talk about this that has real resonance with the public. And they basically believe carers are the most undervalued group in our workforce at the moment. And that is a growing sense of not just they're undervalued, but actually it matters that we're not getting this right.
Helen, I want to come to you in particular on two elements of the question. So one, individuals with learning disabilities and social care, and then also this question of bidding wars and social care agencies, kind of more broadly about how local government is able to commission in a way that kind of prioritises quality and moves away, as Julian said, from some of those cost challenges. So your reflections on those two?
Yes, very happy to. So firstly on learning disabilities and the work that I was doing as a care minister, which was so hard, particularly because it was exactly where NHS and local authority commission social care sort of come together, and you get people kind of stuck in between the systems, or still in NHS care when they should actually be living in community, but with local authority commissioned care. And certainly what and it was hard in the pandemic, but we were pushing ahead on was, on the one hand, actually having the CQC really leaning in on where there was poor quality and just not accepting that any inpatient unit should continue to operate if it wasn't providing a good standard of care. And then the other was trying to really get that relationship working between health and social care, NHS and local authorities, getting into the different areas of the country, because it's all very localised, different ways of working. I would have to say, where it has got to exactly now, I might be turning to Neil. I think James, this is I can't imagine that from you as PPS will have been getting into this particular one. But what I can say is when Parliament is sitting in, it's something which I know I'll be picking up and scrutinising to see where that work has got to, because it's not a huge number of people affected, but it really, really affects those individuals, particularly those who are long-term in inpatient care that's not the right place for them. Then on this, the question of care workers, actually it was really interesting hearing a few of the views there, because on the one hand we've got the problem with care workers' pay being too low, and some care workers leaving to work, for instance, in supermarkets is often the example for better pay, even though they might not be being a care worker. And then on the other hand, I think, Jessica, you were talking about the bidding wars, which sounded like some pretty high rates going, which is
for social workers, but
okay,
not
so
rather
that's
than
for
care
social
workers,
workers rather than
yeah.
for care workers. Okay, so that's a different thing. I guess, I mean, I think where there is a question on where you've got a shortage of staff, the natural thing actually is for pay to go up, which helps people come into that occupation or stay in that occupation. Then the question all becomes, how do you afford it? And to pick up, I think, and it was, I'm still around the questions you pointed me. Liz, thank you for your kind words. I think a really important part of this is the local authority role. It actually picks up something that Julian, you were saying about care packages, and the way care is commissioned makes a really, really big difference, whether it's commissioned looking really, really at the short-term cost or looking much more at outcomes and looking at what the individual really wants. And actually, if you meet the individual's needs of what they really want, it's not necessarily more expensive. It can be better value if you get what the individual needs, rather than having a very cost-focused approach. So, and local authorities, some are good at this and some are less good at this. One of the things in the social care reforms is therefore to be building up the understanding of what all local authorities are doing, and there being a bit more oversight, specifically to enable us to know as a system what works better. Because actually, compared to the NHS has tons of data, a huge amount of information. Social care, it's much, much less data. And I know people hate the idea of data collection. We should make sure it's as unburdensome as possible. But actually, for social care, we could really benefit with more data and information in the system, so that different areas know what's working and what they're doing compared to other areas. That could mean that actually we can make better use of the resources that there are, limited, and give people a better experience of care.
James, let me come to you, particularly on this question about whether social care in particular has been underfunded pre-pandemic, and you were quite emphatic on funding not being the challenge. Is it in that particular part of health and social care a challenge? More broadly, a lot of the questions here on carers, on dignity and value in carers, is that something that the government should be focusing on, or you think there needs to be a real focus on?
There's going to have to be, because ultimately we need the people to provide the service. And undermanning is the critical issue for me. We've got to solve that first and foremost. We've got to also make it more attractive by paying the right wage. And just 2 points to pick up very quickly. The first point about discharges into the community. Best practice does exist. Look at my local ICS. Monthly management meeting, ICS, primary care networks, and guess what, the councils. They're talking all the time together. And discharges in the community don't happen unless the beds are available. So it's called leadership. Wow. How's that for a concept? Leadership. It's called people earning their money and making decisions for the good and benefit of us all. And the second thing, in terms of the wage spiralling, I'm a free market conservative. I'm not a great fan of regulation at all. But where you've got wage inflation like that, and locums being paid £1,000 a day, nip it in the bud. The more money you have to spend on people, the more people you can afford. So ultimately, I think that it's about pragmatism at the end of the day, good management, good leadership.
Thank you. Well, we are at time. Clearly, this is an issue which raises a huge amount of attention. This is the most people we've had in a room that didn't have Michael Gove at the front. And clearly, something about the topic is resonating. Really hope you'll continue looking at Engage Britain Works. They've published a lot of this work. Please do have a look at it. All that's left for me to do is to thank my panel and ask you to give them a round of applause. I was furiously jumping on notes in your question of what the barriers to the work stuff. Are you guys going to be publishing that? Brilliant. Yeah, that's super interesting. What do you guys, the future is here, it's not even history, right?
So, do something after.
Oh, I'm doing it live now. Sorry, we can all
Hi, so Adam's just walking over now, so he'll rush over. All right, cheers, thanks, bye.
I've got to run and make some media now, haven't
How are you? Good. How's it all going? It was really popular and in typical Onward fashion with us, nice and spicy costumes.
Good.
So really welcome. Thank you so much. Everything going well?
Yeah, all really good.
You were next door?
I was next door when I was, and writing articles and stuff, so like...
Have a drink later.
Yeah,
Doesn't sound good.
We've got loads of stuff. Sorry, that's
I work outside. We have a stand, so I'm enjoying being able to sit there in front of it.
Very well. Are you going back to the main place? Good, because I need to go there.
And then I work for Alzheimer's Society. Yes, hello.
very good to
Yes, I know. Yes, Tom's not with us anymore.
Oh no! Tom was great!
I know, he's not even